Welcome to Lecture 3 on the hip. This lecture is focused specifically on how the hip functions during gait for biomechanical, neuromuscular, and clinic decision-making perspective. This is not a memorization lecture. I want you thinking in terms of forces, moments, timing, and compensation. If you understand these four things, you can analyze any gait pattern you will ever see in the clinic. As you're watching this recording, I strongly recommend you pause periodically and visualize a real patient walking in front of you. Everything we're talking about today is something you will observe clinically. Nothing here is theoretical. One key framing concept for this entire lecture is muscles do not activate randomly. Muscles activate to counter external movements. If you understand where the ground reaction force is relative to the hip joint, you can predict which muscles will be active and why. Students often memorize muscle actions in isolation. That fails quickly with real patients. Always ask yourself, what external moment is acting on the hip right now? And what muscle group must respond to it? Let's briefly frame the learning objectives so you know exactly where we're going. First, you should be able to describe normal hip kinematics and kinetics during gait. Kinematics refer to motion, joint angles, positions, displacement. Kinetics refers to forces and movement. You cannot treat gait effectively if you only understand one of those concepts. Second, you should be able to explain how ground reaction forces influence hip joint moments. This is foundational. Ground reaction force location dictates demand. Demand dictates muscle activation. Third, we'll discuss center of mass displacement and how hip and pelvic control influence efficiency. Efficient gait minimizes unnecessary center of mass movement. Fourth, you'll identify muscle activation timing at the hip across the gait cycle using EMG evidence. While you won't have EMG in the clinic, understanding timing improves your interpretation of strength testing and movement quality. Fifth, we'll identify common hip-related gait deviations and their underlying causes. Importantly, we'll differentiate primary impairments from compensations. Sixth, you'll propose corrective exercises and interventions that are phase-specific and biomechanically justified. Finally, we'll talk about using research and objective data to support your clinical decisions. A clinical pearl is that documentation should reflect functional limitations, not isolated weakness. Insurance reimburses for impaired gait, reduced tolerance, and ineffective movement, not a 4 out of 5 muscle grade. Now we're moving into normal hip mechanics. I want you thinking in planes of motion and in phases of stance and swing as we go through this. First, sagittal plane motion. At initial contact, the hip is flexed roughly to 20 to 30 degrees. This amount of flexion is critical because it positions the limb to accept load and allows the trunk to remain upright. From initial contact through loading response and into mid stance, the hip gradually extends. Peak hip extension occurs in terminal stance, typically around 10 to 15 degrees in normal gait. After terminal stance, the hip reverses direction and begins flexing again to advance the limb during swing. This flexion extension cycle is essential for two reasons. First, limb advancement, and second, energy efficiency. Loss of hip extension in terminal stance is one of the most common limitations we see clinically, and it directly reduces step length on the contralateral limb. That means a right hip extension deficit shows up as a shortened left step length. Now let's talk frontal plane motion. During single limb stance, the hip abductors, primarily glute medius and gluteus minimus, must generate sufficient force to counteract the external adduction movement created by the body weight. The pelvis wants to drop toward the swing side. The stance side abductors prevent this drop. If these abductors fail, either due to weakness, poor timing, pain inhibition, or fatigue, you'll see a pelvic drop, lateral trunk lean, or a combination of both. A patient can have normal manual muscle test strength and still demonstrate a Trendelenburg gait because gait is an endurance and timing task, not a single muscle contraction. Next, we need to layer kinetics on top of kinematics. Motion alone does not tell the full story. At initial contact, the ground reaction force vector lies anterior to the hip joint center. This creates an external hip flexion moment in order to prevent the trunk from collapsing forward. The body must generate an internal hip extension moment. This is primarily accomplished by the gluteus maximus with assistance from the hamstrings. During loading response, this hip flexion moment is at its greatest because body weight is being accepted. This explains why gluteus maximus EMG activity peaks in early stance. As we progress into mid stance, the ground reaction force vector moves closer to the hip joint center. This reduces the external flexion moment and decreases the demand on the hip extensors. Later in stance, particularly approaching terminal stance, the ground reaction force shifts posterior to the hip joint, creating an external hip extension moment. At this point, the hip flexors, and most notably the iliopsoas, become active eccentrically. Their job is to control the amount of hip extension and prepare the limb for swing. A clinical pearl, excessive trunk flexion during early stance, is often a compensation to reduced hip flexion moment and unloaded, weak, or painful hip extensors. Now let's connect hip mechanics to the center of mass control. During normal gait, the body center of mass vertically displaces approximately 5 centimeters. The center of mass is lowest during double limb support and highest during mid-stance. Efficient gait minimizes excessive vertical and lateral displacement of the center of mass. The hip plays a major role in this efficiency. Even though it does not directly move the center of mass, sagittal plane hip extension allows smooth forward progression, while frontal plane hip abductor control prevents excessive lateral center of mass shift. When the hip abductors fail, the center of mass shifts laterally toward the stance limb, or the trunk leans excessively. Both strategies increase energy cost and increase stress on the lumbar spine and lower extremity joints. If gait looks inefficient or tiring, think center of mass control first, not just joint range of motion.